I'll make sure I can do this. So we're going to talk about lumbar spine injuries in athletes of all ages. I have no conflict of interest in relation to this presentation. I did present an independent lecture on knee OA, which you have heard about this morning. And the one thing I want to talk about in terms of our objectives, we want to discriminate between the common etiologies of low back pain through an effective history and examine appropriate ancillary studies and develop treatment plans. Now, you guys most of you are primary care physicians, and you know, what's the number one cause of a visit to your office is headache. Low back pain is number 2. And what's the number one cause of missed work days? Is actually the common cold. Number 2 is low back pain. And if, as an adult, you have low back pain, 80% of adults who have low back pain, that seeks them to seek out a primary care physician visit in their lifetime. So it's really very common. This is the most important statistic that I want you to tell your patient who comes in to see with low back pain. You're gonna get better. 90%, over 90%. Go ahead and say over 90% will recover within 6 weeks, okay? All right, so here's some facts. What percentage of adults in the U.S. have had low back pain lasting at least 1 day over the past 3 months? This is not an audience response. This is just questions. Which one is not included in first-line treatment for chronic low back pain? Acupuncture, nonsteroidals, Tai Chi, or yoga. Opioids are considered second-line pharmacological therapy for chronic back pain. True or false? Second-line pharmacological therapy. Acute low back pain generally resolves with which of the following? Time, rest, heat, and or massage. Always massage. Sorry. And which one has the strongest evidence supporting its benefit in chronic low back pain? Nonsteroidals, muscle relaxants, benzodiazepines, or corticosteroids? Let's look at the answers. 25% of adults in the U.S. will have low back pain lasting at least 1 day over the past 3 months. That's a lot. Which one is not included in first-line treatment for chronic low back pain? Nonsteroidals. Which ones do we recommend that people start? Nonsteroidals. Opioids, second-line pharmacological therapy, absolutely false. But what is first-line pharmacological therapy for chronic low back pain? It is nonsteroidals. What's second-line? Tramadol, Cymbalta, or I should say duloxetine. And then third line is opioids. Time, heat, massage. Definitely not rest. If you say rest, they're going to be in bed. They're going to sit on the couch. Okay? You want them to be active, walking, etc. And then again, nonsteroidals has the strongest evidence over placebo. All right. So history is so important. You guys know this. This is what I teach. People come in and they'll know the OPQRST, that's in blue. The only thing I would say about that is old carts, which I like to teach my family medicine residents and the pediatric residents I see, is old carts includes the L and the D, which is location of the pain, and I always say point to where the pain is, and duration, whether or not it's acute or chronic. I add in Ms. old carts because mechanism gets in there and symptoms. So this is what I like people to ask when they come in for any type of musculoskeletal injury, but especially low back pain. Red flags. When we talk about red flags, we always worry about this, right? We want to make sure that we've addressed it. And so certainly the consolation of this, it really, though, goes down to what your clinical suspicion is based on the symptoms they come in with, what you've inquired about, your clinical suspicion, and if you miss it, what are the bad things that could happen? The Cochrane Review looked at 24 of red flags related to malignancy, actually, because what do we hear about? We hear about weight loss, we hear about decreased appetite, et cetera. The only really factor was a history of cancer, was really the only one that was any acceptable diagnostic accuracy. But we also ask these other red flags because if they've had prolonged steroid use, we're worried about, right? We're worried about a compression fracture, for example. IV drug use, for example, in terms of those reasons, prolonged motor and sensory deficit. So these are important red flags when it makes you think about if you need to take the next step in terms of evaluating with further imaging studies. All right, this is a audience response question. What percentage of low back pain in adolescents have no clear identifiable cause? 25%, 50%, 66%, or 80%? And that is correct. 80%, good job. So this was 200,000 charts in an insurance database, and they were followed for about a year, and 80% no identifiable cause. Now, out of the 20% left, 9% was a strain, 5% scoliosis, and that is debatable about whether or not scoliosis causes low back pain, but that's what the diagnosis came out as. Degenerative disc disease, 1.7%, disc herniation, 1.3%, and spondy, less than 1%. So those diagnoses are very uncommon, okay? Very uncommon, even though that's what we talk about. What about this question? What percentage of children who presented to the emergency department with back pain had a pathological cause of the pain? Kids, ED, back pain, oh my God, right? You worry about it. 2.3%, 5.5%. I really had a lot of fun with these percentages, by the way. 10.1%, so random. 24.8%. Oh, you guys are so smart. Okay, you guys have been taking some multiple choice, like pick A, pick D. So it's 2.3%. You guys are exactly correct again. So again, 2.3, and this was a series of children in the ED that were evaluated. And again, these were the 2.3%. Compression fracture with cord involvement, spondylolysis with listhesis, scoliosis, again, whether or not that's a pathological cause of pain, and Schmorl's notes. So it's really, really low. So even though we panic when someone comes in the ED, a lot of times it's really just more anxiety over what's causing the pain rather than a clear pathological cause of pain. All right, good job, guys. And what is the annual prevalence of low back pain in college students? Ha. And significant differences in diagnosis and surgery rates exist between African Americans and whites with occupational low back injuries. True or false? Just think about it, and there are the answers. So, the low back pain in college students, a really large study done out of Colorado showed that 40% had an annual prevalence of low back pain. And again, you add on, and I think Brian Feely's talked about this in terms of these psychosocial variables add to perception of pain. And so knowing that, again, college students, those of you guys who I got a text from my son yesterday because in the middle of finals, and it was a total, I'm so stressed out, I can't, I hate school. And of course, my maternal response was, you've been partying too much. And my daughter says, God, Mom, that is so not maternal. And I went, I'm so sorry. Anyway, this is how the kids feel with pain. And most low back pain represents a pain condition, not a spinal problem. And then the bottom one, which is your second number one on that slide, is true. Absolutely true. And this is one thing that I definitely want to bring out because I think this is really, really important for us to be aware of. And this is for those of us who do primary care medicine, I think it's really, this study looked at workers' comp claims And it was basically just one incident of low back pain. This wasn't chronic low back pain that people came in with. This was a worker that came in with their first episode of low back pain. And Caucasians were 40% more likely to get a diagnosis of a herniated disc. And of all the herniated disc diagnoses, Caucasians were 110% more likely to undergo surgery. And that meant, because of these diagnoses and the outcome, that the African-American workers received lower workers' comp medical expenditures, lower disability ratings, and lower settlement awards. So I needed to put that study in there. Okay, onward and upward. Here we go. So quickly, anatomy. Just know that the disc is 90% water. It acts as a cushion, okay? And so essentially, it wears with age. We all hear about, I just got told that I've been 5'5.5" all my adult years, and at the age of 55, I'm now 5'5.25", and I made them measure me 2 more times, and it's true. So I am shrinking as well. So the disc is a shock absorber, and you can see that if you lose the disc height here, your neuroforamen is going to close, causing less space for the nerve root to come out, okay? And when we talk about the neuroforamina, the SI joints, the lumbosacral joints, these are all different bony anatomies. So that's the first layer. The next thing we talk about, just for you guys to know, pediatric bones, discs, and joints, for those of us who take care of kids, is that we need to know that there's more ligamentous laxity and greater mobility of the spine. And the joints are more immature, and there's ossification centers that are in the spine than in adults, right? That's why they're all cartilaginous and floppy and huggy and wonderful to hold, little kids. But facet joints are more shallow and horizontal. The vertebral bodies, as you can see in this x-ray, are definitely more wedge-shaped, and the spinous processes are less developed. So there's definitely, anatomically, the bony structure is not as stable. When we go to nerves, what do we have to remember? We don't have to remember 31 pairs of nerves unless you're doing some trivia game, but the C7 nerve exits above the 7th cervical vertebrae, and the L5 nerve exits below. So above if it's in the neck, below once it gets below the neck in terms of that. And why do we wonder? I also want to point out here is as your nerve roots exit, remember, there's not just the sciatic nerve that we're dealing with, okay? There's also then the femoral nerve, the anterior plexus that comes down as well. So keep that in mind. What comes out of the lumbar spine goes anteriorly and posteriorly, okay? I don't want to ignore you guys. I'll try my best to spread the love. Dermatomes, find places that are easy for you to remember in terms of dermatomes, okay? Because that's where you're gonna test sensory. And then myotomes. Again, you don't have to test all the myotomes, but just know which ones do what when you're testing strength. And this is all on your handouts. However, know that the dermatomes are highly variable. And you can look, and there are hundreds of dermatomal maps that are just a little bit different. So the consistent spots that I like to point out, the consistent spots are L5 at the first dorsal web space. Okay, I'm not gonna be able to do this, guys, sorry, can't see that far. S1, the lateral foot, okay? L4, the medial malleolus, and then L3 is the medial knee. And for the most of your dermatomes, that's gonna be consistent for most of those maps, okay? And you can see, though, there's variabilities between these two. Okay, muscles. Do you guys remember this mnemonic in med school or wherever you trained? It's not we can't say it anymore. I love spinach. I guess we could say that nowadays. But these are all the superficial muscles, deep muscles. They all support our spine. We have a lot of muscles that support our spine, and they're all very important as we start to build up from the bone. The most important ones that I like to point out too as well is your quadratus lumborum, which is in the back, going from your iliac crest up, and then these lovely, wonderful muscles, the iliopsoas. The psoas muscle, which comes off of the spine, that's a hip flexor, and your iliacus, that comes off of your iliac crest, they form the iliopsoas, which attaches to the femur. This will become important as we go further. So, systematic exam. Observation, sitting, supine, sideline, prone, sorry about the formatting, and standing. And these are some of the tests that can be done in each of these positions. Now, it doesn't have to be in this order. You could go standing. If you go into a room and your patient is standing already, then do the standing part first, and then you can move them over. But the reason I organize it this way is that it makes for a much more efficient exam, because that's really important for us as we are pressed for time often. Okay, and then in terms of looking at athletes, what are the most common lumbar spine injuries? For the younger athletes, you're going to get mechanical low back pain. That can be anywhere from ligaments, muscles to bones, disc type of stuff, spondylolisthesis, spondylitis, herniated disc. And the older, you're going to get more lumbosacral strains, herniated disc, degenerative disc. Now, let's go to our history. Okay, we've got a 50-year-old overweight carpenter playing volleyball at a family reunion, twisted for a ball. Stiffness, symptoms, and this kind of goes through the old carts. So in acute, the entire low back hurts, 2 days duration, character is burning. What aggravates is motion. What alleviates is ice, ibuprofen, pulling her knees to her chest. Radiation, none. Timing, constant during the day, no pain at night, and severity. 4 out of 10 pain, no weakness, no red flags. Here's the exam. Stiffness, discomfort with moving when you observe. Sitting, negative slump, normal reflexes, sensation and strength. Supine, negative straight leg raise, hip full range of motion without pain. Prone, no central spine or bony pain, tender bilateral paraspinal muscles on palpation, negative femoral nerve stretch. Your ham and glute max strength is 5 out of 5. Standing, range of motion, stiff, pain especially forward flexion with spasm, pain when returning to erect position, slow gait, can heel walk, can toe walk, okay. Now, let's talk about some of these things that you may not have recognized on this slide. So, straight leg raise. You guys know what that is, right? Straight leg raise, you see whether or not there is electrical pain coming down the back of the thigh or the side of the thigh, down, we mark whether or not it goes past the knee into the calf or the foot. This indicates Laseg test. What I like to do is if they say, yes, there's pain down my leg, then what I'll do is I'll lower the leg till they don't feel pain anymore, and then I will dorsiflex the foot, and if the pain returns, that's a pretty good indication to me, very sensitive, that there's a radicular component, okay? Now remember the front. This is the femoral nerve stretch test, okay? So it's kind of a reverse straight leg raise, where I am then flexing at the knee, I'm extending at the hip, and I want to see whether or not there's the same electrical shock that's going to go down the front of the thigh, okay? That's called the femoral nerve stretch test. So diagnosis for this individual: acute muscle strain, acute sudden movement or action, overuse typically from poor posture, muscle strength, endurance. She hasn't played volleyball. She just happened to play at the family reunion. It's common. It's self-limiting. This little text says, your back went out because your front went out. Treatment, ice or heat, whatever I think makes people feel better. No good evidence on either one of them. Proper posture and movement patterns, active daily exercise, physical therapy, weight management, and again at the very end, non-steroidals, muscle relaxers if they just can't sleep at night and they're waking up because of the pain. So, case number 2, your 50-year-old comes back in following year, less overweight. Yay. Mechanism of injury, unsure. 3 months ago, began a medicine ball ab workout, increasing running mileage on a treadmill. Really wants to try to run in a half marathon. Symptoms: stiff, weak. Onset gradual. Location: low back, left buttocks region. Duration: 2 months. Character: achy at night. Sharp burning during the day. Coughing and sneezing aggravates it. Ice heat, nonsteroidals, temporary only. Radiation, left outer leg to the toes. Constant during the day, occasionally at night, and 4 out of 10 pain can get worse to 8 out of 10. Still no red flags, which is great, okay? We always ask, any change in your bowel or bladder, right? Which kids have no idea what you're talking about, by the way. Observation, she's standing when you enter the room. While standing, painful forward flexion of 45 degrees, painful right side bend. Able to toe walk, harder to heel walk. No atrophy that you can see. Always have them in shorts. Always have them in shorts. Sitting, positive slump. Decreased sensation, first web space. Alarm bells should be going off, right? Or not alarm, but just like, oh yeah, here we go. Decreased strength, 4 out of 5, left great toe dorsiflexion. What's the nerve root, guys? L5, good. Supine, positive straight leg raise on the left at 45 degrees. Left hip, full range of motion, but pain with external rotation. And prone, tender at the L4-5, disc space greater than L5-S1. Tender at the left SI joint. Negative femoral nerve stretch test. Left hamstring glute max strength, 4+ out of 5, so weaker, absent left L5 reflex. Okay, who checks the L5 reflex? Who checks the patella reflex? Who checks the Achilles reflex? Why do we check those two and not the L5? It's easier, right? Because they're sitting typically when we check those. So how do we check the L5? There's multiple ways to check it, but you can't check it sitting. In my hands, at least, if you can and you have a good way to do it, teach me. Always learning. I'm always learning. But you've got too much pressure on that hamstring when they're sitting. So I like to do it sideline, and then I couldn't find, and I didn't take a picture, but you basically then have the right knee over, and then you have your finger on the lateral biceps femoris hamstring, and then you're doing the reflex hammer right here. You can do it prone as well. I've not been successful this way, but I think if you put your knee under their knee, you could probably do it. But I like this way the best. So you can, and if you're suspecting that it's an L5, please check the L5 reflex, because if it's gone, that lets you know a little bit more about how significant the compression is. Okay, the other thing I want to point out is, remember we talked about how lower here is the nerve root comes underneath its corresponding vertebrae. T10 comes under T10 vertebrae, T11, and vice versa. So that's what we mean. So here we are. Let's assume this is L4 and L5. Well, then this nerve root is L4, right? L4, L5, right? L4, 5. This nerve root is L4 coming underneath its vertebrae. But think about how the spinal cords come down, right? So this is coming out, but look at all these other ones coming down, about to come out at the lower level. If you've got a central disc protrusion, it's not going to push on this one, even though it's this level, right? So this is the L4 nerve root. That's L4 vertebrae, L5 vertebrae. If it's a central disc protrusion, you'll be pushing on S1. I mean, L5 and S1, right? Because they're still coming down. Does that make sense? Do you guys see that? Okay? So this is just geeky anatomy, all right? You have to know this, but gosh, if you guys can understand it, it becomes, low back pain is less of a mystery. Sciatic pain is less than a mystery. Okay, so, let me go back. So it makes sense, right? So if you have a real lateral disc out here and here 3 times, and if it's out there, and then if you're gonna right side bend, this diagram is great because it shows you where you're going to get symptoms, okay? You're not going to get any symptoms here because you're not compressing. But if you left side bend, you're going to get the pain down your leg. But at that same level, if it's more of a central protrusion and you're right side bending, see how you're going to get pain down that leg? So it really matters on where the disc is, the injury is. Okay, I'm geeking out. All right, imaging. So you can get imaging films. Do you have to get imaging films? I would say no. Okay, it depends on the red flags. It depends on their corticosteroid use. It depends on their age. It depends on whether or not they've had, really like fatigue and weight loss. All those things, you put it together. But if you do get it, or if they're coming in with chronic pain, okay, and they've had it for a while. Because again, how much percentage is going to get better of low back pain, even with or without sciatica, depending on? Greater than 90%. All right, so you can see here when you get it is that your disc spaces are going to be narrowed, and these are some schematic examples of what happens. You've got disc degeneration, osteophytes, a thinning disc, herniated disc, a bulging disc, right? And this is probably what most of us have in this room, at least as the degenerative disc, and we're all getting shorter. I'm sorry, except for the really young people in here. I apologize. My age, yes. So, and then imaging. What's the further amount of imaging that we can get? If you get an MRI for this patient who's had this sciatica, this patient who's had a loss of reflex, this person who's weak, I would definitely go ahead, especially with the weakness, and I'd go ahead and get an MRI, and you can see examples of what we're seeing here with the bulge of the disc, okay? Now, again, this is a really good, it tells you that if you've got this, this patient now has an L4-5 disc herniation. Why? Because of the symptoms that this patient has. But you can see if there's L5 or versus S1, what the radicular pain. So I always ask, where is your pain? Where does it shoot? And you can get a good sense of what's happening in terms of your exam, right? If you've lost your Achilles reflex, we're looking at S1. L5 is a hamstring reflex, weakness, etc. Okay, so subspecialty referral for any weakness, loss of reflexes. That's what I would recommend for you guys, okay? A subspecialty referral, and that could be any one of us here in the primary care sports medicine group. That's me, anyone, right? Anyone who is comfortable doing musculoskeletal evaluations. Emergent care, if loss of bowel bladder, saddle anesthesia, okay? Again, how do you describe this to a patient? I describe it as when you're wiping after you have a bowel movement or you go number 2, that's how I explain it to kids or adolescents, and you can't feel the toilet paper, okay? Increasing pain, and really increasing pain, and unresponsive to medications. Physical therapy, positions, posture, positions of comfort, activity modifications, ergonomics are key, and weight loss. Non-steroidals, this is what I do. I don't think there's been any, I haven't seen any papers about this, but this is what I do because pain, we want to not contribute to an increasing pain elevation because of the pain that they're experiencing. So we want to control the pain as much as possible early on. And I have found this to be fairly safe as long as they're timing the ibuprofen with food, and so that they feel like they're doing something. And this is before so we don't get any pain spikes. So I like to alternate it at least for the next, for the first 72 hours or so. And then other meds are very individualized. Prednisone, gabapentin, tricyclics, and narcotics. So I am running behind, and so I'm going to just hit on the highlights, and I don't want to rush through this, but this always happens. I'm so sorry, Dr. Center and Dr. Luke. I have way too much fun doing this. I would like to say in general, for your medications, there are conflicting studies in terms of whether or not prednisone helps. Gabapentin, tricyclics, narcotics, we're just going to put that off the table. But it's very individualized in terms of whether or not you want to try it with them. But the studies some studies say it helps with pain, not with function, vice versa. So really talk to them about whether or not it's an option for them. But if for every study that you find helps, there's going to be a study that says it doesn't really help compared to placebo. Quickly, in terms of epidural corticosteroid injections versus placebo for leg pain and for disability, in the short term, it helps, greater than 3 months. But then after that, compared to placebo, there's really no change. But if you need to get them back to work, if you need to get them decreasing their pain, that may be an option for them. And in patients with a herniated disc confirmed by imaging and leg symptoms that they have for at least 6 weeks, surgery was superior to non-op treatment to relieve their symptoms and improve function. But again, keep in mind that there's a reoperation rate of 10% after 4 years. Now, I think that maybe if I get permission, I can bleed a little bit into the exam, only because a lot of what I talk about up here is about exam. Yeah? Was that a thumbs up? Thank you. All right. The only thing I want to discuss in these slides, really, we talk about, we want to avoid the chronic low back pain patient, right? We want to really avoid our patients becoming chronic pain patients. And so essentially, one of the things that I want to point out is the ACP, American College of Physicians. They came out with a really good paper, about practice guidelines in terms of low back pain. And there's been several other good clinical reviews that have come out. So non-steroidals should definitely be recommended. The strength is strong, that they're much better than placebos in terms of helping with pain, especially chronic low back pain. Opioids, they do have a role. I mean, they definitely are better than placebo, but obviously we need to avoid them because of the risk of dependence, as well as the fact that they're going to be less effective the longer that you use them. Antidepressants should really not be routinely used, and the strength of evidence is really strong, that they're not really more effective than placebo in pain or mental health, depression, or even functional status. When we talk again about the corticosteroids and the gabapentin, again, there are not great studies. There was only one good trial of gabapentin that looked at sciatic type of pain, and again, only short-term benefits, less than 2 months. But again, if you can get past a hump, that's where you may want to make that individual decision to treat them. And then again, randomized control studies, corticosteroids, only really 2 great trials, but again, short-term. Helped with leg pain, but really only short-term. Okay, this is a great study from 1966. It's a really great study. So, I actually, every time I look at this, I laugh, because anyone know what a KPA is? That's what they're measuring. So it's someone know? Yeah, a kilopascal. A kilopascal is a unit of measure. It's 10 grams of mass resting on 1 centimeter squared area. Who knew that answer? And why? Why? You just remember, you're brilliant. But the wonderful thing is, so this was a 70-kilogram man, and there was a catheter placed in the L3 disc. And this would be something that you should print off and laminate and put in your rooms, because this tells it all. What the pressures in the discs. So if you have improper lifting, this is just bending over. How many people bend over a sink to brush your teeth, and you're seeing them, they come in because their back just went like this, right? I mean, this is picking up a box improperly. Look at the pressures in the discs, right? And then sitting. So this is a great comparison to what happens when you're supine. And so I love this diagram in terms of that. So case 3. Okay. Volleyball player, 15-year-old, hurting all summer, worse with spiking, tightness gradual, right-sided, it's lasted almost 3 months, it'll last after volleyball, and non-steroidals will help, took a week off, that helped, no radiation, she sleeps on her stomach, or he, and 4 out of 10 pain. Okay. Moves easily, so sitting, negative, slump test, supine, negative, is very tight in the hamstrings, and the Thomas test is tight in the hip flexors. Prone, tender when you palpate, posterior spine, right side more than left, pain, passively extending the right hip, pain, active back extension, we'll show you what that is, standing, pain with right side bend, right rotation extension, pain with one-legged extension, right greater than left. Okay, so one of the things is looking at the popliteal angle, which we'll do on the exam, so I won't talk about it too much, but that's hamstring flexibility. This is the active lumbar extension. I let them do it so they can push themselves up into how far they can go before they feel pain. And then this is the hip extension test that I do, okay? This is the, you guys can call it different things. People have called, but I call it the one leg standing extension, where all of their weight is on one leg, so on the right column of the spine, and then I have them extend, okay? And then I'll do it on the left leg as well. Okay, so this gal, let's just say you could do radiographs if you wanted to. 3 months of pain, she's an elite volleyball player, aren't they all? And, you know, she's got to get back to play in the tournament because she's got to get recruited, you know, by a Division I college team. So do we do X-rays? A lot of your patients demand it, and you guys know how hard it's like talking patients out of antibiotics. What's easier to do? So I do talk to them about it quickly, most of them, but if I do any X-rays at all, and I'm concerned, and on this patient, I would be concerned because she's been playing club volleyball since the age of 6 or 7, and she's been extending. So I want to make sure that there is no issue with her spine in terms of spondylolisthesis or spondylolysis. So, but if I get any images, I'm going to get only 2. Because why? When I was in training, I learned how to do 5 images. Oblique views. And why? Because you've got this cute little Scotty dog that you can see. And if you see a Scotty dog that's got a collar on his neck, that means that he possibly has a fracture of the pars interarticularis, and this Scotty dog and this fracture means that there's a problem, okay? Now, you could also get a bone scan, which is what I learned when I was in training. You can get a bone scan. You can get a thin cut CT scan to look if there's any fractures, or you can get an MRI. And this is an inversion recovery sequences. It's very sensitive for bone edema. Now, quickly, lots of radiation. That's my whole thing, right? So especially in younger people, the more that we expose young kids to radiation, their organs are more sensitive, and they're going to live a lot longer than we are, and so they've got all these years to have the side effects of having too much radiation. So we want to try to avoid that. So this is why an MRI is so great. See the sensitivity on the inversion recovery? This is a stress injury to the pars here, and meanwhile you can also see fractures on these sequences as well. This is a CT scan, and you can see the fracture line through here as well. But an MRI is a great first step. So now, if unfortunately, sometimes I have to do X-rays because insurance companies won't authorize an MRI until there's X-rays. I hate that, but I'll only do 2. Sometimes just 1, honestly, like the lateral. Okay, treatment is controversial for spondylolysis, and why? Again, it's because of the studies. The studies are pretty are challenging because we can't really predict if it's just one-sided versus both-sided. I will be more likely to brace if it's both-sided, because if both sides progress to a non-union, then it's a 50% to 75% risk that it's going to progress into spondylolisthesis, where there's slippage of the vertebrae, either grade 1 or grade 2. So I want to prevent that from happening. And then if they end up having that, then their risk of having surgery as an adult is higher, or intervention or chronic pain. So, but this is a whole educational process. So if you decide or you think that this is an issue, then I would refer them to a subspecialist as well to discuss the pros and cons. What we really want to make sure is that they do get stable and strong. Remember, all the muscles, that is the brace. That is the bracing for their spine, are muscles. So we want to make sure that they're flexible. We want to make sure that there's not too much anterior rotation, and they're return to play when free and strong. Now, the complications, we talked about the spondylolisthesis, okay? Facet joint dysfunction. Quickly, I talk about that because in the older population, we could be worried about that. The only thing I want to say is this. We talk about when you rotate to the right and extend, it's going to load on the right joints. When you rotate to the left, etc. Know that it's a capsule. So the facet joint, if there's inflammation in your facet joint, and because it's a capsule, yes, it could hurt when you extend, but it may also hurt when you flex because it's inflamed, that capsule's inflamed. So just because they hurt with flexion you shouldn't eliminate that it's not facet joint. Okay, and then this is an example of the inflammation on the MRI, the fluid that you can see in a facet, okay? All right, yay, almost done. And quickly, we're gonna talk about this person. I'm not gonna get into it, it's just to say that there's a person that comes in and they say, yeah, intermittently my back hurts. Sometimes it feels pretty good. I go for days it feels okay. Sometimes it really kills me. It's typically just one-sided. And this particular person didn't have any pain when he went camping over the weekend, but then came back to work, sits a lot, is a programmer, and is hurting again, training for a marathon, hurting into the hamstring. Okay, on exam, positive Thomas test and positive Gillette test. Okay, nothing ridiculous. So this is the Thomas test, and we're going to demonstrate this. This is all due to the iliopsoas and the rectus femoris. So essentially, this is a good test. This is normal. We want the thigh to be flat. We want the knee to be bent at 90 degrees. This is abnormal, okay? Now, here's an example. This is one of my patients, truly, hip flexion really tight. And this is another, again, example of how it's tight off the bed, knee flexion not at 90 degrees, you see that? And you can also look at it from this point of view. If they're really abducted like this leg is, I didn't take an example from the front, but if they're abducted out here, then we also know their IT band is tight. So I do this test much more than I do the Ober nowadays. You guys remember the Ober? Harder test to do. And then this is the Gillette's test, where I look at the motion of the ilium on either side. So I'm going to show this to you. So I did have audio, but that's okay. Don't worry about it, John. So when they bring up their knee, that's a positive Gillette's on the left. So we're going to play it again. And there's a spine model that I always have. So essentially, with the right knee up, the right ilium should rotate posteriorly. And then on the left side, this individual hikes up, okay? And this is because of the pelvis is anteriorly rotated. And what happens is hip flexors are tight, and this does not rotate forward when they do that. And that's why their hamstring feels tight. Because it's not rotating forward, the femur still has to stretch forward, the hamstring gets tight. The pelvis does not posteriorly rotate. And that's why people get this intermittent SI joint pain, high hamstring pain, and it's due to the tight hip flexors. I just want you to think about it because it happens a lot. We have a sitting society. We're seeing this all the time, okay? Rule out a room disease if they're tender over the SI joint and they have morning pain. Okay, and this was an anthropological researcher who basically said indigenous cultures don't have low back pain, and it's because their spine is shaped differently than ours. And I disagree with that, and actually we all kind of disagreed with her. It's really because of our society versus people who are outside, active, et cetera. And I challenge you, when we have little kids and we see little kids at the playground, this is how they pick up their toys. This is how her mother picks up her toys. And something happened between the ages of a toddler to now us, and is it modeling? What is it that changes the way that we move our bodies? So we need to all prevent back pain with a healthy lifestyle, exercise, correct posture, lifting correctly, sleeping properly, avoiding prolonged positions. Standing desks are amazing. Achieve and maintain a healthy weight. Justine, come on up. There's usually not a quick fix for this. And 90%, again, over 90% will recover within 6 weeks. So a doctor who cannot take a good history and a patient who cannot give one are in danger of giving and receiving bad treatment. History is key. And then the only thing I put this Chinese proverb is because we do have workshops. We're going to do something right here now. But tell me and I'll forget. Show me, I may remember. Involve me and I'll understand. So hopefully most of you will be able to attend some of the workshop this afternoon. Thanks.